Hi guys, Dr. Harris here. We are going to talk about postoperative management of the shoulder in this lecture. Here are our objectives. Big key points. We're going to review very common surgical interventions utilized for shoulder pathologies. Caveat to that, just like there are a lot of shoulder differential diagnoses and special tests, there are equally a lot of different surgical procedures that can be performed at the shoulder. This lecture is in no way comprehensive of all of those. The goal for this lecture is to learn a couple of key surgical interventions to get a basic understanding so that you can then build upon that when you're in your clinical rotations and practicing in the future. So it will be up to you to do some additional research on your own, review postoperative reports, and have meaningful discussions with your clinical instructors should you happen upon a surgical intervention that you're not familiar with. The biggest key to really understanding postoperative management of the shoulder is to really understand the anatomy and the mechanics that are occurring at the shoulder joint, and then linking those to the procedure that was performed. So that will be key for you with studying and reviewing. It will help you to identify relevant precautions for each procedure and to effectively describe the differences between the procedures. We'll also review some associated complications with many of these procedures as well that you should be aware of moving forward in rehabilitation with your patients. The primary goals with surgical intervention are to attempt to restore nearly a normal anatomy and biomechanics, and in doing so the hope is that we are decreasing long-term pain and improving long-term function. But that's where the surgeons really rely on the rehabilitation team because we're the ones that are spending hours per week with our patients. So we're the touch points. We're the ones that are educating our patients. So it's really up to us to know how to safely progress our patients back to their desired level of function and to really set them up with a solid injury prevention program and regular physical activity program to promote long-term joint health. So just a reminder to review your normal anatomy at the shoulder, so nervous system, vascular system, musculoskeletal system. Make sure that you remember the normal mechanics at the shoulder, so our major force couples, our arthrokinematics at the scapula, the glenohumeral joint, the AC joint, and the SC joint as well. We're going to discuss a couple major interventions for each of the common shoulder diagnoses. So we'll talk about instability, the rotator cuff, fracture, and joint replacement. On the right side of the screen are just some pictures of common slings that you're bound to run into as you start to get more clinical experience. Following any type of shoulder surgery, a patient will be placed into a sling for a prescribed amount of time. That period of time will be dictated by the surgical team, but then they will rely on the rehab team to touch base with their patients to make sure that they're compliant with use, that they understand proper fit, and that they understand proper activity modification for basic activities like dressing and grooming, so that they're not placing any extra stress on the surgical site itself. So we'll start with instability, and first we'll discuss a common intervention for a slap tear. So just a reminder to go back and to review the different types of slap tears. The classification continues to get more detailed and complex. The picture on the right side of the screen is a very general description of the common 4 types of slap tears. A is type 1, which again is just fraying at the superior labrum. B is the type 2, where you have the detachment of the superior labrum and the biceps complex from the glenoid rim. C is the type 3, which is the bucket handle tear of the labrum. And D is the more complex type 4, which is a combination of a bucket handle tear that also extends into the biceps. We'll discuss B, the type 2, in a little bit more detail as far as surgery is concerned. Just know that A and C are a little bit easier to manage surgically. The surgeon is going to use an arthroscopic procedure to address this. Arthroscopic means that they're making small incisions at strategic points at the shoulder, and we call those portal incisions. They'll insert a camera into one, and then they'll insert whatever tools they need into the other incisions. It's considered to be minimally invasive, which means that we're hopefully reducing a risk of incision and postoperative stiffness. For A and C, typically a surgeon's going to go in and just debride the unstable tissue back to a stable base. D is a little bit more complex. It's probably a combination of a repair with maybe a debridement as well. It's very surgeon dependent, which is why we're not going to talk as much about D. And we'll spend the rest of our time talking about image B, or a type 2 slap tear. With this population, it's common to see surgical management via a slap repair in a younger population, very commonly with overhead athletes. Indication for surgery would be failure of conservative interventions, which this commonly will range from medication or an subacromial injection combined with extensive physical therapy. Even following that, if an athlete is unable to return to competition at a high level, this can serve as an indication for surgery as well. The steps to the surgery include debriding any degenerative tissue, debriding the glenoid to prepare a bleeding bone bed to bring blood flow to the area to promote healing. They'll drill holes into the glenoid articular margin. They'll place anchors into those holes and then pass sutures from the anchors through the labrum to essentially pull it back down to the glenoid rim to stabilize it. So the overall goal, restore anatomical stability of the labrum and the biceps complex. Commonly, with precautions, we'll see a patient in a sling anywhere from 4 to 6 weeks. In general, the range of motion is going to be staged per the surgeon's protocol, which just means there's going to be limitations in the amount of passive and or active motion that can occur in each plane. The biggest thing is that there's going to be some sort of a limitation on an isolated biceps contraction, so elbow flexion and supination. For a minimum of 6 weeks, however, I've seen this in the literature for up to 12 weeks. This is going to be a conversation that you're going to want to have with the surgical team to make sure that you are on track with what their protocol entails. So a little bit more detail as far as the big picture rehab here. It's going to be based upon the individual patient and the surgeon's preference, always. The first thing you're going to want to know following any surgery is, were there any other procedures that were performed? Just a fun fact, we commonly will also see a rotator cuff tear with a slap 2 tear. It's very common in overhead athletes. So you're going to want to know if a rotator cuff repair was also performed or if the rotator cuff was addressed at all surgically. This will change your rehab progression moving forward, so it's a very important conversation that, again, you're going to want to have with the surgical team. As I mentioned earlier, your range of motion is going to be staged over the first 6 weeks. Following any surgery, we always want to make sure that we're optimizing mobility proximally and distally, if we can, within a safe range. So at the shoulder, that means making sure that we're maintaining cervical, elbow, wrist, and hand range of motion initially. Now, keep in mind that we need to avoid an active or an isolated biceps contraction, so that might change the type of mobility exercises that we prescribe at the elbow, wrist, and hand, and I want you to think about how you might modify that. The biggest thing is we want to avoid positions that are going to place increased tension, both passively and then actively, on the biceps. So when we think about range of motion, we have passive range of motion, we've got active assistive, and we've got active range of motion. Typically, we're going to start with our passive mobility and work our way up through those, depending on when the surgeon wants us to start to initiate some sort of contractile muscle activity at the joint. So when in doubt, start with passive and clarify. If we're thinking about passive range of motion, usually passive external rotation and abduction are the two that are staged throughout that first 6 weeks or so following surgery. When we think about active and active assisted and passive stretching, that can change. Usually Later on, sometimes up to 3 months, we're still limiting terminal stretching into extension or internal rotation behind the back, again, because that can place tension through the biceps complex. Another position that can as well is external rotation with the shoulder abducted to 90 degrees. So those are all ranges that you're going to want to make sure are clarified with the surgeon or on their protocol, and make sure that you're abiding by them. As far as active range of motion, another position that could potentially place increased tension through the biceps complex is forward elevation, so either flexion or abduction with the elbow extended. Think about ways that you might be able to modify that. Once the patient is cleared for strengthening, we always want to start with emphasizing our normal scapular kinematics first, so normalizing the scapulohumeral rhythm while respecting any tissue healing that's occurring. Again, we're avoiding that isolated resisted biceps contraction now for that first 6 to 8 weeks still, and even following that, you're going to want to slowly progress with any form of biceps loading to make sure that we're not adding any increased traction or stress right at that repair. We want to avoid any type of mechanism that's going to peel that labrum back off the glenoid. Normal outcomes following this surgery include returning to golf anywhere from 3 to 4 months, depending on the patient and depending on their specific post-operative course. Returning to work 3 to 4 months, depending on work-related responsibilities. So whether or not they're a desk worker versus maybe a cashier versus a warehouse worker, and what their specific job demands entail. Throwing can take anywhere from 6 months to a year. And then common complications, and a lot of these you're going to see some repetition from one procedure to the next. I would say one that's unique to this procedure is re-tear, as far as peeling back the biceps labral complex. However, sometimes this can occur and we may not even be aware of it. So always just pay attention to how your patient is presenting in clinic. So how is their range of motion? How is their pain? Are they having any mechanical symptoms? What do their scapular kinematics look like? What does their strength look like? One study that I found listed that there can be as high as a 43% re-tear rate. However, when they compared groups of patients who on MRI demonstrated a re-tear versus those who did not, there is really no significant difference in function. So this becomes a problem when a patient is having mechanical symptoms, significant pain, and they're not progressing typically. With that being said, you want to make sure throughout your course of rehab that you're never putting a patient in any unsafe situation. So you want to make sure that you abide by those precautions to try to minimize the risk of re-tear the best you can. Infection, review your common signs of infection, and then a common complication with many shoulder surgical interventions is postoperative stiffness and or adhesive capsulitis. So when you're doing your chart review and you're looking at a patient's medical history, you want to make sure that you flag or kind of are aware of any comorbidities that might put them at risk. So I want you to think about and maybe make a list of common comorbidities that might place a patient at risk for impaired tissue healing, potentially developing adhesive capsulitis, anything along those lines. Also, depending on the complexity and the type of surgical approach, this may also predispose a patient to develop postoperative stiffness. So minimally invasive arthroscopic surgeries have a lower level of risk compared to, say, an open procedure where there's a large incision and several layers of tissue that were dissected in order to gain exposure to the joint. Okay, so moving on. So now we're going to talk about anterior instability, which could be addressed via an anterior capsular shift. There's other names for this procedure as well. The major indication for this is a history of recurrent anterior or inferior shoulder dislocations. It's typically going to present with other pathology as well, whether that's a rotator cuff tear, labral pathology like a slap tear or a Bankart tear, bony pathology like a Hill-Sachs lesion. This procedure is also performed arthroscopically. Basically what they do is they reduce the volume of the glenohumeral ligament complex, and if any other pathologies are present, they're going to address those as well. Again, the first question that you should be thinking and that you should ask is, are there any other pathologies or procedures that I need to be aware of in designing my rehab program for my patient? By reducing the volume of the ligament complex, the surgeon is essentially addressing the permanent plastic deformation that had occurred from just the patient's history of instability. So with the anterior capsular shift, the goal is to obtain a pain-free and stable shoulder. You want your patient to have adequate mobility, strength, and neuromotor control for desired activity level. In patients with anterior instability and an isolated capsular shift, the surgeon is going to tighten the capsule and the glenohumeral ligaments by placing anchors along the anterior and inferior interface of the labrum and the glenoid. They're going to pass sutures through the capsule, and then they're going to tighten the capsule towards the glenoid without disrupting the labrum. Normally they use about 3 anchors. The shift is approximately 5 to 10 millimeters at each anchor from the inferior to the superior direction. The surgeon is going to determine the level of tension based upon a combination of things: the preoperative patient history, the preoperative patient exam, in addition to a more thorough examination with the patient under anesthesia immediately before the surgery is performed. So this picture kind of outlines that procedure. Common precautions: sling for about 6 weeks. The biggest rehab guideline following this surgery is staged range of motion. So these patients are typically have a lot of range of motion going into surgery. I mean, that's why they have instability, right? So it's not necessarily going to be very hard to gain their range of motion afterwards, but we have to do it in a very graded progression, again, to make sure that we're not perpetuating that plastic deformation at the glenohumeral ligament complex. So we don't want their patients to regain this range of motion quickly and then dislocate again. We really need them to scar down strategically so that their shoulder has more stability than it had before surgery from a static perspective. So this source is listed in my references section too. This is one of the major articles that most rehab protocols are structured around for this particular procedure. So just guiding principles. We want to make sure that we have a thorough understanding of the surgical intervention itself. We want to make sure that all anatomic structures are identified and that they're protected, but that they're stressed systematically to promote tissue healing and stability. So by doing that, we have to appropriately select and apply techniques at different levels to stress these healing tissues, and we have to really make sure that we're staying on top of the initial mobilization period and being systematic about the rate at which we progress range of motion. So what do you need to do? You need to go back and review your arthrokinematics at the shoulder again. You need to think about which portions of the anterior and inferior capsule are stressed at various degrees of flexion, abduction, external rotation. The first phase of rehab following this procedure is often based upon these principles, and that's why we stage range of motion. And this table is a very common outline of what a lot of protocols will include as far as staged range of motion during that first 6 to 12 weeks following surgery. So what's the big picture rehab? So it's going to, again, be based upon the individual patient and the surgeon's preference. Did they have any other surgical procedures that were performed? So you stage the range of motion over the first 6 to 12 weeks per the surgeon and per the patient's presentation. Again, we're optimizing our cervical, elbow, wrist, and hand range of motion initially. From a strengthening perspective, we always want to make sure that we normalize our scapular kinematics. The patient must have full active range of motion and symmetrical strength without scapular dyskinesis to progress to functional training. This is just a general rule of thumb for most shoulder rehab as well. It may not be listed on every slide, but it's something that you want to remember. And then outcomes. Return to work anywhere from 4 to 6 months, depending on the patient and their job tasks. And return to sport 6 months or greater, again, depending on the patient and depending on the sport and depending on the level of competition. Alrighty, so moving on to addressing the rotator cuff spectrum. So we're going to start with shoulder impingement, which is commonly addressed via subacromial decompression, which is exactly how it sounds. They're going in and they're opening up space beneath the acromion. Indications for surgery: failure of conservative interventions for subacromial impingement syndrome, which these span anywhere from medication, injection, rest to physical therapy. And it's typically also due to some sort of an anatomic factor that is contributing to the presentation of impingement, whether there's bone spurring and degenerative changes or a hooked acromion or chronically inflamed bursa. I've seen a variety of specific anatomic factors addressed via the surgery, which include resecting the coracomial ligament, performing an anterior acromioplasty, resecting the distal end of the clavicle, just resecting any osteophytes that are at the AC joint, or performing a bursectomy where they actually take out the bursa. Being able to get your hands on a post-operative report will help you to really get a better idea of what it was that the surgeon addressed in surgery. This is also an arthroscopic procedure as well. The goal is to expand the space between the acromion and the rotator cuff tendons. As far as precautions are concerned, the sling is primarily worn for comfort. So depending on the surgeon, anywhere from 24 hours to 2 weeks. You want to keep the patient's irritability level in the front of your mind as well. So the pain management is an indicator for using the sling, but you also want to make sure that you're optimizing range of motion. No repair was performed, so we want to regain their range of motion and their strength as tolerated, and avoid any post-operative stiffness. So it's a little bit of a balance between the patient's level of irritability and the need to minimize any unnecessary complications. So with the rehab on this one, again, there's no anatomic repair to consider. The biggest thing is early pain management. You want to maintain your cervical, elbow, and wrist mobility and regain full shoulder range of motion as tolerated. Again, normalizing our scapulohumeral kinematics and progressing strengthening as tolerated. This rehab is typically dependent on post-operative pain, irritability, and the patient's long-term goals. And then we have our rotator cuff repair. Again, a rotator cuff repair is considered following failure of conservative interventions, medication, injection, rest, physical therapy. We know that rotator cuff tears are common, and we know that there is a percentage of the population that has a rotator cuff tear that has no pain and has no functional limitations. We also know that there is a pretty large group of patients with a rotator cuff tears that will do just fine with physical therapy and will be able to return to their desired level of function. So the biggest indicator for surgical interventions at my practice is a failure of conservative management. Important factors to consider: age, pain, irritability, response to PT, level of function, anatomy, and any comorbidities. Again, the rotator cuff repair itself is more commonly now performed arthroscopically. There are probably still surgeons out there that will do an open procedure, and again, this increases the risk for post-operative stiffness and is falling out of favor as a result. What will happen arthroscopically is that the surgeon will first inspect the subacromial space for any debris. It's very common for a subacromial decompression to be performed in conjunction with a rotator cuff repair. The tendon attachment surface will be debrided to promote blood flow, and then sutures are going to be passed through the tendons and then fixated to the humerus. There may be other other procedures that are performed as well. So again, you're going to want to communicate with the surgical team to make sure that you're aware of all relevant procedures that were performed. So the goal following a rotator cuff repair is to decompress the subacromial space, release any adhered tissue, and then securely fixate the tendons back to their place of origin. Precautions. So a sling with an abduction pillow for roughly 6 weeks, depending on the size of the tear. The range of motion is going to depend on the size of the tear. And then lifting restrictions. With any shoulder surgery, there's usually some sort of a lifting restriction, and this is going to come into play typically when the sling is discharged, and it may be anywhere from 1 to 5 pounds initially, and then commonly 5 to 10 pounds for a minimum of 3 months. Again, this is a question that you're going to want to communicate with the surgical team over. Big picture rehab. So range of motion and rehab are going to depend on the size of the tear as well as your prognosis. Small tear typically progresses a little bit faster compared to a large tear, but not always. Small tear is typically staged with range of motion over the first 6 weeks, while a massive repair is going to be staged over the first 6 to 8 weeks or longer. The goal is to minimize tendon load for that first 6 weeks. So we're going to very gradually and systematically progress our strengthening. We want to think about passive range of motion versus active assistive range of motion and active range of motion, and what type of contractile structures we are utilizing during our progressions. We start with our scapula and our deltoid first because we do not want to place any increased tension over the healing repair until indicated. So just keep in mind that at 12 weeks, a rotator cuff repair is approximately 25% the normal tensile strength of an intact cuff. So that's not to say that we might not start gradually and safely loading the cuff prior to 12 weeks, but we're not going to systematically overload it until it can. So sorry about that. Apparently my dogs have decided that they wanted to chew up my Christmas tree, so I had to take a quick break there. Anyway, so we were talking about tensile strength of the rotator cuff. So we have to really just respect tissue healing here. It's very common in our practice. A lot of our surgeons don't even want us actively loading into external rotation or internal rotation if implicated until the 12-week minimum mark. Just to really make sure that we're promoting just biological healing at the site of the repair. So make sure that you discuss that with your surgeon. In general, we want to avoid cyclic loading. So that means like quick, repetitive range of motion that could potentially cause repeated microtrauma at the site of repair. So when you think about exercises that you might have seen in clinic, the two that come to mind for me are a pulley system and an upper body like arm bike or bicycle ergometer. And this is what we mean by cyclic motion. So taking a patient through a quick repeated motion, we found in the literature has caused repetitive microtrauma at the rotator cuff, which actually has caused or led to failure of rotator cuff repairs. So this is something that I personally and many of my colleagues do not include in our rehab progressions when a rotator cuff tear has been performed. It can take 4 to 6 months for return to function and 7 to 9 months or longer to return to sport following this type of procedure. It depends on the patient's goals and also post-operative clearance from the surgeon. Common complications. So the biggest is going to be failure of the repair. The literature has told us that a large or massive tear typically fails in that first 3 months, where a small to medium tear more commonly in the first 6 months. Signs of trouble to look out for in rehab. So if you see a significant shrug sign with shoulder flexion and abduction in combination with external rotation weakness or a lag, or a significant increase in external range of motion, external rotation range of motion, and or pain with any of these factors, you should have a high index of suspicion for potential re-tear. I can think of one specific case where this occurred, where it was problematic, and it was a patient following a massive cuff repair. They were cleared to start physical therapy at 2 weeks post-operatively. He arrived with his sling properly placed, but his first complaint was, I went to shower yesterday, I didn't have my sling on, and I felt a pop in my shoulder. It was painful then, but it's not so painful now. So we talked to the surgeon, and the surgeon wanted us to just kind of watch and see how he is progressing. Over that first 8 weeks of therapy, he regained full range of motion, but was never able to regain more than approximately 45 degrees of active flexion and abduction. He had significant external rotation weakness. He had persistent anterior shoulder pain that hovered anywhere from a 6 to an 8 out of 10. They went in and did an MRI, and he had retorn his repair, probably at that incidence that he described during his initial evaluation. Postoperative stiffness is pretty common as far as rotator cuff repairs are concerned as well, especially with a massive repair. The more structures that are addressed in the joint, the more at risk a patient becomes for a chronic inflammatory process and for an accelerated scar tissue healing response. So you need to, again, take into account their comorbidities. What this patient's going to look like to you. They're going to look drastically behind on their range of motion goals based upon what was established by the surgical protocol. And then infection, don't forget your common signs of infection. Okay guys, now on to a discussion of management of fracture. So common fracture in the elderly population is going to be a proximal humerus fracture. There are all kinds of different classification systems for this. The near classification is the most common, and it's going to classify fractures based on the number of parts that the bone is broken into. So the higher the number, the more complicated. For example, the picture on the right shows a 4-part fracture. The more parts tend to result in lower outcomes in general. And the question is always, do we perform surgery or not? And if we perform surgery, what kind of surgery do we perform? So assessment is critical. We really have to rely on imaging for this one. X-rays are going to be your first in line. For a more complicated fracture, the doctor might also order a CT scan to get a more detailed understanding of the pattern of the fracture. We need to not only take into account the number of parts, but also the bone quality of the individual and if there's any potential soft tissue injury. So that's where an MRI might come into play. Vascular supply is going to be essential to take into account from a healing perspective. And as a result, if there's a high level of soft tissue injury in addition to fracture, they may not even be able to stabilize the fracture via an open reduction internal fixation. They may have to go straight to joint replacement, which we'll talk about later on in the lecture. A Cochrane review in 2015 concluded that there's insufficient evidence that supports any one particular treatment type for a proximal humerus fracture. There's moderate quality evidence that compared with no surgery, surgery doesn't necessarily result in a better outcome for patients that have displaced fractures that involve the neck of the humerus. So it really is going to be a case-by-case basis. So a proximal humerus, ORIF, or open reduction internal fixation. It's going to depend on the type of fracture. Where's the fracture? What structures are involved? Is there any soft tissue, nerve, or vascular integrity? An ORIF, what happens is they make an incision to access the fracture. So this is an open procedure. The fracture is going to be manually reduced, which means the parts are going to be essentially put back where they belong. And then a metal plate is going to be attached to the bone with the use of surgical screws, like we have here in the picture on the left. Precautions: sling anywhere from 6 to 8 weeks. Bone quality or bone integrity is one of the factors that's going to dictate the length of sling use. They're going to be restricted weight bearing, which means no pushing or pulling using the upper extremity. They typically have restricted mobility into specific planes depending on what parts of the humerus were involved, and then lifting restrictions as well. But this will all be on an individual case-by-case basis. Let's see here. So big picture rehab. So we know that there are a lot of muscles at the shoulder, and there are a lot of attachment sites onto the humerus itself. So we need to take into account kind of our force vectors and what types of contractile structures may be placing undue tension on healing bony structures during the course of rehab. So it's going to be very patient specific, and tissue and bone quality again is going to be essential. So we're going to start with our phase of joint protection in the sling, optimizing cervical, elbow, wrist, and hand mobility. And then we're going to restore our range of motion safely based upon the surgeon's guidelines. So this picture kind of dictates some of our force vectors a bit, but just consider supraspinatus, infraspinatus, and teres minor can all cause posterior and superior displacement of the greater tuberosity when they contract. Subscapularis can cause medial displacement of the lesser tuberosity and internal rotation of the humeral head when it contracts. Our pec major and deltoid can also cause anterior and superior displacement of the shaft of the humerus. So depending on what parts of the humerus were involved with the fracture and the repair, we may need to modify when we start to add in active range of motion into particular planes and strengthening. Again, we want to normalize scapulohumeral kinematics prior to significantly advancing our strength within the surgeon's guidelines. And for this function should be our top priority. I will say clinically, the more complex the fracture, the less likely we are to regain our full mobility and strength. And patient comorbidities will play a huge role in this as well. So again, we want to think about function, what that patient wants to get back to doing, and designing our treatment program to tailoring it to that while abiding by any relevant precautions as well to make sure that we're staying safe. Common complications. Adhesive capsulitis is a very common complication following the surgery given the severity of trauma that typically occurs in the area. A delay in receiving PT can also impact this. So say a patient falls, has surgery, and then is in an inpatient or skilled nursing facility for a period of time and not really working on their range of motion within their precautions as much as they should be, that might place them at risk for development of this. The significance of the injury, the surgical approach, and any presence of comorbidities are also factors to consider. Subacromial impingement as well. So the altered scapulohumeral kinematics, decreased joint mobility, or even hardware can lead to that. In addition to infection, failure of the hardware, whether there's poor bone stock and the hardware just doesn't take to the bone, or if there's avascular necrosis of the humeral head from impaired vascular supply following surgery, or just malalignment of either the bone or the hardware. These can all be complications following an ORIF. Okay guys, we've made it to the end of the lecture. We're going to talk about joint replacement next, which is an end-of-the-road procedure. Indication for joint replacement is underlying advanced glenohumeral pathology that results in persistent pain and loss of function with failure of conservative interventions. So common pathologies are arthritis or rheumatoid arthritis, rotator cuff tear arthropathy, which just means that there's a chronic rotator cuff tear that's been present, and as a result, you've been getting increased compressive forces through the humerus and the glenoid and the AC joint. That's led to degenerative changes over time. Osteonecrosis, fracture, again, so if there's a complicated proximal humerus fracture with a significant soft tissue injury, a surgeon may elect to perform a joint replacement as opposed to an ORIF. Decisions. So how do we choose between a total shoulder arthroplasty or a reverse total shoulder arthroplasty? Well, there's some factors that we want to take into account. So let's at least talk about what a total shoulder arthroplasty versus a reverse. It's exactly like it sounds. So on the left is a picture of a TSA. So that's when they replace the head of the humerus and the glenoid. And then on the right is a reverse where actually the ball is now where the glenoid was and the socket is where the head of the humerus was. So factors to consider: medical history, the mechanism of injury, the integrity of the rotator cuff is a big one, and the level of function. And we'll get into this a little bit more. So let's start with the total shoulder arthroplasty. So our main goals are a resurfacing of joint surfaces for pain management, to adequately balance the soft tissue surrounding the joint, and to restore motion for improved function. In order to perform a TSA, the patient must have adequate integrity of their rotator cuff, because we're going to need to normalize those force couples between the cuff and the scapula following surgery. The humeral component will replace the head of the humerus. It's going to be made of cobalt and chromium-based alloys. It consists of a rounded ball that's attached to a stem, and it fits into the bone. So it's going to fit right into the humerus. The glenoid component is replaced with the socket, and it's typically made of plastic. Depending on the bone stock, so the quality of bone with the patient, integrity, density, quality, the components will either be held in place with cement, or they're going to be press fit and rely on kind of bone healing or bony ingrowth. Precautions following surgery. So most patients are going to present in a sling. They may or may not have the abduction pillow depending on the surgeon, and this sling will be utilized anywhere from 4 to 6 weeks. The subscapularis, you need to find out what's happening with the subscapularis. The incision is going to be made over the anterior shoulder. The subscapularis itself is going to have to be taken down in order to gain access to the surgical site. And because of that, we typically have to limit passive external rotation in order to protect the subscapularis, because they have to commonly repair it when they're closing. So we limit external rotation. We also limit extension so that we're not placing excessive tension through that anterior portion of the shoulder, and then also weight bearing through the shoulder from 6 to 12 weeks depending on the surgeon. So what are we educating our patients? Well, we're educating them to maintain a visual on their hands and elbows the entire time. So we don't want them moving into extreme ranges of motion, particularly extension, abduction, or external rotation, as it's going to overstress the subscapularis in the anterior capsule. So the pattern of dislocation following a total shoulder replacement is similar to that of an anterior shoulder dislocation. So even once they come out of the sling, we want to try to avoid them of those extreme ranges of motion as a result. Big picture rehab, again, surgeon dependent. Did they have any other procedures performed? So sometimes if there's a small rotator cuff tear, they'll do a total shoulder, and they'll also do a small rotator cuff repair as well. So you just want to know if that happens and clarify relevant post-operative precautions with the surgeon. You want to avoid combined motions initially. So you want to optimize cervical, elbow, wrist, and hand mobility. Perform shoulder range of motion, so passive and then active assistive and active once cleared, in one cardinal plane at a time. And again, we're limiting repetitive or cyclic motion, especially if there's a subscapularis repair or any other rotator cuff repair that's performed. The goal is to normalize scapulohumeral kinematics, again, prior to significantly advancing its strength. Full recovery from a joint replacement can take 1 to 2 years. So patient education and home programming is key. Following this type of procedure, as far as range of motion goals are concerned, most patients are going to achieve close to full flexion, external and internal rotation. We just have to give it time from a biology and a tissue standpoint to heal before we really progress terminal ranges. Normal return to sport, so golf, tennis, swimming, it's all possible. It's usually 4 to 6 months at the earliest, but it can take 1 to 2 years. Definitely not out of the question. It is very patient dependent and requires planning with you, the patient, and the surgeon. In general, osteoarthritis, in the absence of any other comorbidities, has the best outcome following the surgery. They're the ones that are going to regain nearly full range of motion and function. Rheumatoid arthritis or any other inflammatory disorders tend to present with a lower outcome, just given the high level of nervous system sensitivity from the chronic inflammatory condition. So they're less likely to regain full range of motion, and if it's a highly irritable patient, they may have a lot of difficulty regaining overhead function. So it can be a case-by-case basis depending on the comorbidities that are present. Common complications. Again, infection, especially since this is an open procedure. Instability of the components. So what that looks like: persistent pain, poorly controlled swelling, weakness, mechanical symptoms, a failure to progress as expected. Subscapularis failure is the big one. So what does this look like? It looks like a sudden increase in external rotation motion and associated internal rotation weakness. There's typically a mechanism for this, a mechanism of injury, and they'll present with a positive belly press or lift-off sign. Rotator cuff dysfunction can be common as well. So what does this look like? Atrophy of the cuff, a shrug sign, a lag sign, and external rotation weakness. Reverse total shoulder arthroplasty. So the biomechanics are significantly changed now because of this. So because the biomechanics are changed, which we'll talk about in a little bit, there is more of a potential for dislocation or instability following a reverse compared to a standard TSA. So the precautions for this particular procedure are going to be unique and different compared to the TSA. So I'm going to jump forward to a slide and then we'll come back to this. Okay, so biomechanics. With a reverse total shoulder, the glenoid fossa is going to be replaced with what we call a glenoid base plate and a glenosphere. So glenosphere, glenoid base plate up here. And then the humeral head is going to be replaced with a stem and concave cup. So what does this do? Well, it's going to alter the center of rotation of the shoulder joint. So here's the center of rotation of the shoulder with the total shoulder arthroplasty. Here's the center of rotation, the black diamond, with the reverse. So it's moved or shift medially and inferiorly, and it's kind of hard to appreciate as much in this picture. It's very subtle. But yes, it shifts medially and inferiorly. And so as a result, that's going to increase the moment arm of the deltoid. So the red line is the moment arm of the deltoid. So let's go back to kinesiology for a second. Torque is force times the moment arm. The moment arm is that perpendicular distance to the center of rotation. We all on board there? So if the moment arm for the deltoid increases, this is going to allow for greater torque produced. Okay? So again, the center of rotation of the shoulder is going to shift medially and inferiorly. As a result, the moment arm of the deltoid increases, which allows for more torque to be produced by the deltoid, the anterior deltoid specifically, following a reverse total shoulder procedure. Okay, let's go back. So, indications for this procedure: arthritis plus an irreparable rotator cuff tear. So that's the big deal with the reverse. The rotator cuff is no longer intact. Also a complex fracture or a failure of a total shoulder arthroplasty with a deficient rotator cuff. Again, if the cuff is not functional. So let's go back to this picture one more time. So the anterior deltoid can produce more torque because its moment arm is much larger in the reverse. If the rotator cuff is no longer intact in this patient population, then the change in the mechanical advantage for the deltoid becomes essential with postoperative rehabilitation. Your deltoid is going to become the primary elevator of the shoulder. So our job becomes optimizing function of the deltoid to compensate for a deficient rotator cuff. All right, back one more time. So precautions following surgery. As I mentioned, instability is more common, or the risk is higher in this population. So again, sling with or without an abduction pillow, depending on the surgeon, for 4 to 6 weeks. Big range of motion precautions. No reaching behind the back or across the body. 6 to 12 weeks. This can be longer depending on the surgeon. So the pattern of dislocation following this procedure is going to be combined internal rotation, adduction, and extension. So educate your patients. Keep elbows and hands in direct line of sight the entire time. Don't reach behind your back or across the body. And then big picture rehab for a reverse. So like we kind of talked about, deltoid function is essential, as is scapular function. So the anterior deltoid is essential for shoulder elevation. It's common to achieve anywhere from 80 to 130 degrees of active elevation. So there's a lot of variability depending on the patient. Sometimes the teres minor is still intact. And if it is intact in the patient, which you can gather from reading a patient's operative report, sometimes you can achieve maybe 15 degrees of active external rotation, but the expectation is that the patient will not achieve full active external rotation because they don't have a deficient cuff, or because they have a deficient rotator cuff. Joint protection is essential, so you want to optimize your cervical, elbow, wrist, hand mobility like in our other procedures. Again, with just as with a TSA, you want to perform shoulder passive range of motion in one plane at a time. And for the reverse, we want to try to initiate it within the scapular plane. We typically only start with flexion and external rotation. Initially, again, because we want to abide by those post-operative precautions. We always want to avoid hyperextension. So what does that mean? Educating your patient to place a pillow behind their arm when they're laying down. When you're working on a patient, having a towel roll placed behind them. And then once they are cleared to initiate internal rotation by their shoulder, or as indicated in their protocol, we will work into internal rotation. So again, just like with all of our other shoulder procedures, sometimes an additional procedure is performed. So occasionally a surgeon will perform a subscap repair in a reverse total shoulder, just like with a total shoulder. So you do want to find out if that's the case, and I've had maybe 2 cases like that. And in that instance, when we're thinking about range of motion, we're also going to want to make sure that we limit passive external rotation there as well. So as you guys can see, really communicating with the surgical team is essential for the post-operative patient population. When we're thinking about strengthening, we need to keep in mind that the scapulohumeral rhythm is going to be altered in a patient with a reverse shoulder replacement, just given that the mechanics of the joint are now very different. So one study found that normal scapulohumeral rhythm in healthy adults is roughly 2 to 1, and in adults following a reverse total shoulder, it's about 3 to 1. So just know that. Just know that it's not going to look like a healthy normal shoulder would look, and educate your patients on that too. Like especially if they have a reverse on one side and no joint replacement on the other, just making sure that we're establishing realistic goals. That in addition to long-term recovery that occurs following joint replacement, your range of motion is likely not going to be the same one side versus the other following this procedure, and it will probably look different. As far as return to sport, under the discretion of the surgeon, it's going to be very low impact, and again, 4 to 6 months. Common complications, stress fracture of the acromion can be a common one. So when we think about stress fractures, those are repetitive stress type injuries. Typically it's an insidious onset from repeated overuse. So how can PT influence this? Well, let's think about the acromion and the anatomy. So if we're thinking cyclic, repetitive overhead motion and having our patients perform those types of exercises in the home setting too, this can potentially predispose a patient, especially one that say has poor bone quality or bone stock, to this type of injury. How do they look in clinic? Rapid decline of active range of motion, pain with palpation at the acromion. You might see pain with resisted manual muscle testing to the deltoid, and it may or may not show up on imaging. Big picture is we want to limit cyclic motion here so that we're not overstressing the acromion. Scapular notching is very common, and it's not really something that as PT we can significantly either avoid or influence. What it is it's erosion of the neck of the scapula, and it's due to impingement of the medial rim of the humeral cup and adduction, so adduction. So if you look at the figure here, it's impingement of that medial part of the humerus against the scapula. And there's different grades to it, like grades 1 through 4, more or less. Dislocation, we've kind of talked about the ranges of that already. Again, typically there's a mechanism of injury for that. Instability, so instability without a dislocation, what does that look like? Persistent pain, poorly controlled swelling, again, weakness, any form of mechanical symptoms, a lack of progression. They'll be able to see it on imaging. It typically presents as like a lucency or kind of like a fuzzy image around the margins of the replacement on an x-ray. And then infection. Again, don't forget your signs of infection. Alrighty, thanks for hanging out with me and talking about postoperative shoulder. Here's a list of references that I used, and many of the articles are helpful for just getting your bearings. So keep that list with you as you go into your clinical rotations too for more information. Alrighty, thanks you guys.